Over to you, Rax.
Are we, Prajwal, are we live?
Yes,
okay.
we are live. Yes.
You can make it full screen.
Yes, you can proceed, please.
Good evening, everyone, for this webinar on an extremely important topic, the essentials of home-based monitoring and virtual care in COVID-19. I have much pleasure in welcoming all of you, as this is an extremely relevant topic for India in particular, and also the doctors and other frontline healthcare professionals who are dealing with the pandemic in India. I would like to start off by welcoming two guests who have a lot of experience with handling COVID in the US, Professor Trish and Dr. Matthew, who have kindly accepted to help the Indian ecosystem with their best practices. I would also like to welcome Dr. John, who has put together this program and helped to bring this together. So I'll quickly introduce Project Step One. I think a lot of you are already associated with Project Step One, but for those of you who are new to Project Step One is a volunteer-driven and non-profit collective of doctors, technologists, and concerned citizens. We work with the governments in state and district governments in India, and via telemedicine we help doctors get connected to COVID affected citizens. And we started off last year, and we have over 7,000 doctors, several thousands of paramedics and counselors, and several thousands of non-medical volunteers who are trained in COVID management protocols and helping COVID affected patients. We currently are live in 18 states in the country, and on a daily basis, we receive 85,000 or 85K new COVID patients onto our platform, whom we have to talk, triage, and further put on to doctors and other healthcare providers on hospitals for treatment. We are monitoring on a daily basis over 400,000 patients who are COVID positive and recovering from home. So we are actually dealing with a huge scale, unprecedented scale that we have never seen before. And thanks to our dedicated team of doctors, other volunteers, and technology professionals who are keeping this, and operational professionals who are keeping this backend going. We obviously are always looking for more hands. So please visit www.projectstep1.org and help us with more volunteers, both doctors as well as non doctors, to join this movement to help other help COVID affected people and bring this pandemic under control. I would like to now call upon Dr. John Sushil, who is from the George Institute. I welcome him, and over to you, Dr. John, to introduce our guest speakers today.
Thank you, Rax. It's an honor and privilege to be on this call. And like you mentioned, we are really at the forefront of trying to respond to the COVID crisis in India through using technology. And it's an honor and privilege to welcome Professor Trish, who's a professor of primary care and health sciences and a fellow of the Green Templeton College of University of Oxford. And she's been on the forefront of bringing evidence really around the best practices in primary care responses, including the most recent airborne transmission that has really helped us also to prepare ourselves better in terms of how do we adopt COVID appropriate behaviors. And she is one of the leading authorities on introducing innovations and scaling them up. And really a pleasure to have you, Trish, with us this evening. Thank you for sparing your time. I know you have a heart for us in this part of the world, and therefore you agreed at such short notice. Thank you. Look forward to hear from you. And we have Dr. Matt, who's a national clinical lead for COVID response at the NHS England, and he would be sharing with us specifically how virtual care and remote monitoring at home, specifically a project called Oximetry at home, and how that has helped in addressing the problem that they faced in the UK. Over to you, Trish, to set the tone and lead us through this discussion. And
yeah, I'm just having a little bit of trouble getting my video to work. So I'm going to actually ask if Matthew can go first while I play around with my technical problems.
Sure.
No problem. And thank you very much for your generous introduction. And it's an honor to share this platform both with you and with Trish, who I respect greatly. I just want to pause and say what a remarkable job you do. I am staggered and amazed at the sheer breadth and scale of your work, and to have so many volunteers, to see 85,000 new patients a day, and to have 400,000 patients that you're monitoring at home is incredible. My hat's off to you, and we are honoured to support you in what is a very worthy crusade. These are some slides that Trish and I have been working on, and others, to try and describe, I guess, what we've done with COVID oximetry across our country. And this is not about telling you what to do. This is just an example of what we did, in the hope that it helps you, and that the mistakes that we made during our management of COVID are mistakes that you can learn from and do better than we did with. So I work as an acute physician, so I work in a hospital, and I was a GP and a community doctor in my career previously as well. And I see things quite clearly as being community-based, really, in regard to COVID. And that's despite working in a hospital, because I think the key impact we can make is actually in the community with COVID, both in terms of how we manage it, prevent it, but also identify early when patients deteriorate with COVID, and then how we best utilize our monitoring and our ability to reassure patients to ensure that we also protect our healthcare system going forward. Now, in the UK, much like other parts of the world, we noted right at the start of COVID that patients were presenting incredibly unwell, often with an absence of breathlessness. So in some ways, we had to rewrite the medical textbooks, because that's not what we are used to with respiratory illnesses. We had to think more broadly about trying to identify sick patients, because cases like this were coming up time and time again of people not actually complaining of breathlessness, but actually being significantly ill with COVID. The term silent hypoxia was coined to describe that. And therefore, as a result of that, your standard community interventions were not going to win the battle here. And this was about thinking outside the box, I think what else we could do in regard to monitoring people's oxygen levels. And this came about from frontline care, noting that patients recording their own oxygen saturations and clinicians working with patients seemed to achieve that earlier recognition and helped protect patients. Trish, right at the beginning of the pandemic, realized the importance of the role of remote assessment in COVID. And this was a hitherto relatively undescribed art, I guess, particularly in the phase of respiratory illnesses. So this was a really important initial practice pointer as to what we should do in regard to COVID, how these services should be set up, the connectivity of what electronic systems would be required, both from an audio and visual perspective, the processes of actually kick-starting it off, and what the key questions might be. And these questions and this advice is as true now as it was then. The examination and how you can best do that on the end of a telephone, or indeed a televisual link if you're lucky enough to have it. What self-recorded patient observations might be useful, and how that might influence what actions are then taken, and indeed what follow-up, and when patients should really worry. What are the red flag symptoms or the worries, the things that are red alerts? And it prompted the question really about, particularly in regard to oxygen saturations, what if we could do this everywhere? What if we could empower the population? And what if we could take things forward in a way that actually drove a personalized care agenda? This need for a validated warning score across the community settings was really brought to a head by this article and many others. And Trish and colleagues have been working hard to develop a recap score that we hope will really assist us in this setting going forward. From an evidence perspective, we hit the ground running. So we felt really, right at the beginning, we needed to tie up what was happening in the community, what was happening in ambulance services, and what was happening in hospitals in terms of outcomes. What were the predictors of bad outcomes at home that we could intervene on at an earlier stage to try and reverse the disease trajectory? So what that involved was using large-scale data to actually analyze populations and look at what their physiology was doing at home, and then what eventually happened to them as an outcome. And what we found was that the most predictive of these home-based monitoring elements was oxygen saturations. And the key magic figure was around 92% or less than 93%. And as soon as you reach that point, you have a bit of a jump in terms of certainly mortality, but also intensive care admission at varying durations past that reading, 5 days or 30 days. And this is a preprint we're about to get published, but the links are all clickable and we will share all the slides after the presentation. And that led to really a national policy change to look at 92% or below being our cutoff for England, with that amber band of 93 to 94% being your bit in the middle where you keep an eye on patients because obviously they can improve or deteriorate from there. But 92% or below being our call for patients going into hospital urgently for an assessment. And that reflected in what we then published in terms of our safety netting guidance, standardized across the country. During the same study, what was really interesting is that we noted nearly 2/3 of those admitted to hospital actually had normal oxygen saturations. And that led to us thinking, is there an opportunity here to also add protection for the healthcare system here? Because not all of these patients potentially needed to come in. And what would be a safe line in the sand in terms of prompting the question, does this patient really need a hospital bed? Does this patient really need to stay in hospital? And we found this was true of the 92% or below range for intensive care admissions as well as deaths. And this led to the purchase of around 700,000 oximeters, basically to lend to high-risk symptomatic COVID patients at home for monitoring by their GPs or hospitals, with an accompanying national mandate for this policy in all settings across the country. There's been a lot of press around whether oximetry works in patients who are non-white. And I think the bottom line statement is the benefits significantly outweigh the risks. And we desperately need further research to establish and understand what we've seen in some putative letters thus far. We actually we've nearly released about 500 to 600,000 oximeters across the country, and we've not had a single incident of reported inaccuracy in patients of non-white color. And what it prompts is really pragmatic guidance going forward. One, establish the baseline oxygen levels in the patient you are monitoring and use that to judge future deterioration against. And if that can be done in a well patient, all the better. Use your clinical judgment. Do not abandon it, and monitor trends of both the symptoms a patient is describing as well as the saturation readings the patient is recording. And this is all written in our pulse oximetry guidance. And it's just practical guidance about not throwing the baby out with the bathwater and thinking benefits outweighing risks. In terms of the what next within virtual care, it was very much a case of those two mantras: protect patients and protect the healthcare system. And that involved training and empowering patients to self-monitor and self-escalate, using a combination of oximetry and partnership, proper trust that they would get help if they deteriorated and if they became hypoxic, and clear public messaging around that about who, what, when, and how they should call for help should they start to feel ill, and what those significant symptoms that they should really worry about should be. And indeed, that protection of the healthcare system and the flow through the emergency sector is an incredibly powerful and important safety mechanism, because if our health systems become overwhelmed, we cannot help more people. So it's really critical we put lines in the sand about when patients should come in, what the safe oxygen level was for both admission and also, crucially, when patients can be discharged. Because we cannot keep well patients in for days and days and days within a very stretched, resource-intensive hospital environment when we are under intense pressure. The what here was very much a guided, dynamic program. It was flexible. It wasn't one size fits all. So the thing that was unified, I guess, was the fact that the inclusion criteria for this virtual remote monitoring was all around high-risk patients. And the early data demonstrated being 65 or above, or under that age with significant diseases or comorbidities appeared to be the group that had the worst outcomes with COVID. So that felt like a natural fit for our inclusion criteria. The rest of it was a flexible monitoring model based on what the resource was in each environment. And this is true for England. Not everywhere was able to add apps or computers. The most basic model involved informing patients what to look out for in terms of symptoms and when to seek help. And actually, that symptom control is incredibly important because people get worried. They need to understand what normal is and what is a worrying set of symptoms and signs. The next elements, if people were lucky enough to have a pulse oximeter, which is now quite a cheap and easy thing to obtain, we released quite a lot of guidance on how to use it, including printed material on diaries, as well as instructions, both in terms of video formats, multi-translated, which we're very happy to share all the links to, and then animations as well on YouTube. And these were wildly popular in terms of, I guess, informing the general public in what to look for in terms of oxygen levels and severe symptoms and when to seek help. And this was tied in with, in some higher resourced environments, telemedicine and an ability to have an ongoing relationship and conversation with the patient. Training resources were produced to try and assist patients in this way. And in more advanced systems, again, apps and dashboards of hundreds or thousands of patients were kept running to enable that cross-system surveillance. But this is a blended model and flexible. There is no perfect model here. And even the basics of asking patients to look for severe symptoms is good and great and worth doing, whatever your resource. About this time, we were also looking at whether there are effective treatments in the community, and we looked at budesonide quite closely as an inhaled treatment. And unfortunately, after the principal analysis, what we found was that it doesn't improve hospitalizations or deaths. It does appear to have an improvement in self-reported recovery, about on average 3 days shorter, but this could all be placebo effect. So it is allowed off-label for prescribing across our country, but not for wide-scale use because the evidence is not strong. So if you were a mild patient sitting on the virtual COVID ward, what you needed to really understand was what normal looked like and what are non-worrying symptoms, i.e. when not to contact health services for help, because these are very burdened, stressed healthcare systems that risk being overwhelmed. We need to find the patients we need to get involved with first. And part of that process was understanding what the more benign symptoms of COVID are. So having a cough, diarrhea, headache, a loss of sense of smell or taste was not associated with death or severe outcomes, admission, intensive care. They were actually more associated with better outcomes in terms of odds ratio predictions. And what was really important was the general public knew that and also had to support themselves through the recovery, what the normal time period of the illness was, about 4 weeks. And recognition that actually a condition called long COVID existed in terms of future rehabilitation. So that patient information and instruction was absolutely critical in gaining partnership, useful partnership with patients, the public, in what COVID was and how best to protect themselves and the healthcare system. With the other side of the coin being what to look out for with severe symptoms with COVID. So what are the symptoms associated with bad outcomes, such as intensive care admission and death? And they are quite simply breathlessness, severe myalgia, severe fatigue, chills, rigors, and confusion. And if you have any of those symptoms, you're at increased risk of a bad outcome. Coupled with that, patients needed to understand what trends were all about in terms of their symptoms of breathing, worsening, and the trends of oxygen saturations if they were using oximeters. The timings of when people are likely to deteriorate was really important, both from the system perspective, but also patients. So silent hypoxia is most common, days 5 to 7 post-onset. And 7 to 11 days post onset is when, if you're going to develop significant breathlessness, that's where it's likely to happen. And understanding that enabled our system to tweak increased frequency of follow-up calls and reviews with patients at those time periods, those critical junctures. The other important advice was how urgently to seek help should your symptoms really radically deteriorate. And what we noticed from certainly our recommendations and our early evidence, it was a sudden worsening of breathing that was particularly associated with bad outcomes, an inability to complete short sentences in speaking and when sitting down, and being breathless when doing nothing, when resting. And all of this was published in our safety netting guidance to the general public. And these sorts of interventions are incredibly useful. In terms of how you do this at scale, we used a combination of webinars, an ongoing forum, and very generous sharing across all our networks. And it was really important that we engaged all elements of society. And we haven't nailed this. We haven't got this perfect. But it's absolutely a key element, the socio-political and religious elements, as well as medical fraternity, that need to be engaged in order to take this condition forward. The actual ins and outs of a large-scale improvement project and distribution project in an attempt to standardize what we did everywhere. This adaptation and sharing of resources, and there was such generosity of sharing between our different regions. That's one of the things that really made it. That collaboration, that closeness, and that feeling of a one team type approach. Resources were produced for e-learning, and this was incredibly important to train our healthcare professionals with how to manage patients who had COVID in a remote setting, followed by a whole host of resources, including guidelines, pathways, policies, the evidence, and an ongoing discussion forum that we held electronically. We had around 1,000 members on that, and it was a really vibrant discussion point where people brought frontline problems and conundrums to the national leadership team to enable that really transparent two-way conversation. The toolkits for how you do it were also incredibly well read and popular. And this led to a really, really strong collaborative network going forward for both learning and improvement. And what that led to over time, around those mantras of identify it early and protect patients. Don't admit patients unless you really need to. But if they do need to come in, they need to come in urgently. And how do you promote self-discharge? And this started off with low numbers initially in December and quickly ramped up to essentially be universal by February. And this was one of those programs that really took flight based on the fact that it was really strongly supported by normal clinicians and patients at the front line and their management teams around them. And we divided our country up into 5 to 10 million population regions called academic health science networks, and they were pivotal to this. Small bite-sized areas around a national collective aim. The pathway itself was really simple. So looking at the symptoms and whatever tools you had to assist that, the clear lines in the sand of when people come in and seek help. And then at the hospital end, if there is a discharge, thinking about that home self-monitoring. And if there's an admission, then thinking about early supported discharge as soon as you possibly can. And then the follow-up therein based on the resources you have. And the clinical pathway is a little bit more complicated, but not really. It's about what your mild, moderate, and severe lines in the sand are, and enacting a degree of how you escalate based on that risk. And with the recap score coming, we will have more evidence to base this on. We found early on that exertion desaturations were an important clinical sign, although poorly validated to this point. And that when we saw patients with COVID, we often put them through their paces in terms of walking tests. And those that did badly or had an oxygen requirement in the imminent future appeared to have a drop in their oxygen levels on walking. So an important possible early signal, and again, tied in with our overall strategy. In terms of that supported discharge, it was about 3 main areas. 1, identifying patients early who were suitable for discharge. 2, authorizing that discharge through clinical leadership teams. And 3, ensuring safe transition from the hospital to the community with a real checklist of comms. And improving trajectory of patient was really important here, as was what oxygen level or NEWS2 score was going to be your line in the sand for discharge. In terms of that review element, with more senior clinicians came a bit more flexibility on how severely unwell patients were allowed to be discharged with, and what stability and improving trajectory was all around with those patients. To that, we also thought about oxygen treatment on discharge for patients who were dependent on oxygen, but actually were in the recovering phases. The communications therein are really important because that's where we often drop the ball and where most safety incidents within all care happen. These services can be set up incredibly quickly. And some of my colleagues managed to do this sort of setup within 60 minutes. Staggering stuff, simple model, oximetry and a paper diary can be done unbelievably quickly. And the early evidence around oxygen discharge is that it is a safe and effective means of discharging patients. And this is a recently published study looking at COVID home monitoring patients discharged from acute hospitals on oxygen concentrator treatment, something that might be really applicable to my country and India in general. So well worth a read. The other thing about discharging patients who've had intense treatment is that actually it can continue in the community. And NICE in England released this statement to allow that ongoing treatment with dexamethasone for patients discharged home who had begun it in hospital. To that point, we'd been keeping people in on dexamethasone in order to finish the course or sending them home without dexamethasone, having begun it, which led to a large number of readmissions. I urge you not to make the same mistake. So consider this sort of protocol of how to send people home on dexamethasone, and also the diabetic monitoring of patients in the community who are at risk of hypoglycemia with dexamethasone treatment in the community. This is for severe patients who were admitted who had an oxygen requirement in hospital, not for initiation in the community by this protocol. The impact from our program seemed to demonstrate a remarkable reduction in length of stay overall, with particularly a reduction in the 7 to 14 day length of stays, and an increase in the 3 to 7 day length of stays. So we shifted it down by getting people out sooner. Now, it's hard to definitively say cause and effect. Obviously, other treatments came along. We were better at treating COVID in general and spotting it. But this was probably a very constructive additional element to that. We've seen a drop in mortality rates by around a third between our first peaks of COVID a year ago and how we are currently doing with our mortality rates. And over the same time period, we've been doing analysis of those patients who have had home monitoring, and our overall mortality rate is less than 1% for patients on this model. Again, amazing data compared to where we were, where the mortality rate was around 14.4% during our first peak. It would be lovely to do some joined up research with your group in due course to see if we can prove impact at scale. And in some hospitals around the country, what we've demonstrated is an increase in that virtual ward remote assessment management and a reduction in all-cause emergency admissions to do with COVID. Again, this is our aim. Keep people out who need to be at home and admit those who need to be in hospital early and discharge people early where possible. And what we've seen from studies around the world is that if you monitor patients with home monitoring with COVID, you can have really remarkable impact on their future requirements for both ED attendance, so the emergency department hospital assessment, and also emergency admissions or hospitalization, with quite a dramatic reduction in hospitalization, 0.62 and 0.70 odds ratios at 30 days and 90 days respectively for patients admitted to our home monitoring program. This is incredible news and evidence that this approach works. And then a final question. So we've touched on admission avoidance. We've touched on early discharge. What if your hospital system becomes completely overwhelmed? And reflecting on our conversations with colleagues from Wuhan in China and what they did with their 13,000 bedded hospitals, these Fangdang hospitals, what they found was that there was probably a role for this low acuity admission area, using oxygen concentrators and beginning patients on oxygen with SATs of less than 93%. It's really interesting that China found exactly the same line in the sand, less than 93%, as we found in England. I suspect it's the same everywhere, and perhaps that's the magic number. And what these authors suggested in this BMJ article was that the UK should consider perhaps refashioning what it does with nightingales. The question, I suppose, is whether these are lessons applicable to India as well, and whether A low acuity admissions area might be sensible if hospital systems are being overwhelmed, perhaps with lines in the sand of 90% or higher or less than 90%, and then monitoring and an ability to trigger a hospital intensive care facility attendance if a patient becomes unstable or unresponsive to oxygen concentrated delivered therapy. This is food for thought. There are no lines in the sand, and this was the sort of model we were working up in my region should we become completely overwhelmed with COVID. We were lucky enough to avoid that through a combination of the COVID virtual wards and home monitoring program that staved off so many admissions. So this is my final slide. The WHO have now recommended this model across the world. This is about trust, this model, between the public, politicians, religion, and indeed entire countries, as well as the healthcare system. We need to trust each other and work together to protect what we are really here about, which is namely the patients, but also the healthcare system as a whole, to prevent the overflooding of our healthcare systems and being completely overwhelmed, whilst also keeping people safe. So we're really grateful for this opportunity to talk to you. We can't wait to see what you come up with, because I think what you come up with will provide a lesson for the rest of the world in how best to manage COVID going forward. And I look forward to your innovations and wonderful collaboration. Thank you.
Thank you, Matt. That was wonderful. I wish we can translate all of that straight away and get going now, but we do have a little bit of a journey to go. I'll turn over to Trish and ask her to give her insights. Trish, you've been really researching this topic very intensely, and some of the key lessons that you would have from a perspective of somebody who's looked at evidence very closely. I know Matt has presented a lot of it here, but if we were to give us 3 key points, the formula or mantra for success for India, what would those be?
My goodness, I wouldn't presume to tell India how to manage. I mean, as Matt says, I think you guys are doing amazingly well in an incredibly difficult situation. And I speak as someone who lost my own mother to COVID. I know you're working at immense personal risk. You're risking your own lives, your family's lives, and you've seen a lot of suffering. So my heart goes out to you. In terms of the research base, I've worked very closely with Matt, and the presentation he gave is based on our joint work, but I think we haven't quite got the results of an ongoing validation study of the recap score, and we should have those very soon, within the next probably 2-3 weeks. But without any doubt, oximetry is becoming, as Matt says, a very, very important component of community-based care, just as it's an important component of hospital-based care. And oximetry prior to admission, oximetry to help decide which patients to admit to hospital, or indeed to put on home oxygen, and then oximetry, as Matt says, on discharge to decide who's well enough to go home, and also monitor patients as they are convalescing. Now, the other thing I've been doing research on, and I wonder if it's worth just taking 5 minutes to talk about, it's a different topic, but it is all this evidence around airborne spread and what we should do about that. I can show you something very briefly if you'd like. Are you happy for me to do that?
Sure, Trish, by all means.
Yeah. Okay. So let me just share. Now, I'll just open this one. So I'm sharing my whole screen for a reason. We published this paper in The Lancet, 10 Scientific Reasons in Support of Airborne Transmission of SARS-CoV-2. And I'm not going to go through that now because you can all get hold of it from The Lancet if you want. It's open access. There is no scientific doubt now that this virus spreads through the air in tiny particles which float. Now, there are a number of implications for that. And a colleague of mine only this morning sent me a really fantastic set of guidance that she had prepared, which I'm now going to show you here because it's so wonderful. So this is from my colleague Rebecca Inglis, and she prepared it for a country called Laos, near Thailand. I'm sure you know it well. And I thought so it's not designed for India, but I think I spent quite a lot of a few months in India a couple of times, and I think it will be relevant. It's all about improving ventilation in recognition of the virus being airborne. And incidentally, I'm supervising a PhD of a student who's looking at tuberculosis, which is another airborne disease. And this applies just as much to other airborne respiratory infections. So the first thing to convey to your colleagues working in the clinics and the hospitals is outside is safest. If you can see patients outside, when I went for my vaccination, I had my vaccination in a tent, in a very cold tent, actually, because it was winter in the UK, but very, very important. Open the windows. Windows open is much better than air conditioning on. Open, and you can see in this room that there's windows open on 2 walls, which means there'll be a through draft. So not just open windows, but the breeze coming through. Thirdly, avoid overcrowding. And I know that's difficult. I've been to India, I've worked in Indian hospitals, but the more people that are in a room, the higher the risk. So avoid overcrowding anywhere, get people to wait outside, and ensure that everyone is wearing a mask. Here's another one. Set your extractor fans to blow outwards so that it's pulling the air out of the room, and leave them switched on. Check the direction of the airflow by holding a piece of tissue. Look at that. Fifthly, unblock your air vents. Apparently, there's a lot of blocking up of air vents that happen to stop the drafts. Well, just go and check those air vents and make sure they're not taped shut. Use fans carefully. It's no good just having the fan in the room if there's no supply of fresh air. So if you can put the fan near an open window, that's much better. Then the air, you get much fresher air. Always ensure that the fan is blowing from a cleaner area to a less clean area. I'm sure you can work that one out. You've got your hot and cold zones, no doubt, like we have. As I say, caution with air conditioning. Be very, very careful. They're not providing fresh air. It might feel fresh, but it isn't fresh. Use open vehicles for transport. We did some research about a year ago now in workers that were being taken to meat factories, and they were being driven there in closed vans with no windows. And guess what? A lot of them caught COVID. Staff rooms, very risky because people remove their face masks. So don't do that. Grab your lunch, go outside and eat it. And finally, optimize your mechanical ventilation systems. So this is now a little bit technical. I can supply this guide if you're interested, and I'm sure the organizers of the conference will be able to pass it on. But I just thought that was quite a useful, practical application of that rather dense Lancet article that we published. So that's all I'm going to say, because I think the most important thing is that you, the audience, have some time to ask questions, or the John and other people are going to ask on your behalf. So Matt and I are now ready to hear your questions.
Thanks, Trish and Matt. Rags has actually posted the first question. Rags, you want to kind of say the situation and why we're asking this question, so that you can have it.
Sure. Yeah. So I will first describe a little bit about the situation in India, I think, so that you get the context of where some of the questions are coming from. In pretty much most of the big cities in India, we are out of beds, and making home care and home isolation work is no longer a matter of choice; it's a necessity. And I think there are several challenges that come with this necessity, with the country and pretty much everyone who's working to fight COVID in the country is trying to deal with. But the first and foremost is, Matt, we understand the role of oximetry in assessing the risk, as well as using that in our protocols. But a vast majority of the people in our country don't have access to pulse oximeters. And even if they have, they're very expensive right now. And most of them are not very accurate. So anything that you could help the audience with, what are the things that could be done? Are there ways that we can assess the risk in the absence of a pulse oximeter? This I know is an area of research for you, Trish, and also for you, Matt,
I'm just looking to try and find the recap score. Maybe Matt, can you share your screen and find the slide with the recap score? Now, this is where we were just over a year ago in the UK. We didn't have oximeters, not because we couldn't afford them, but because I think they were made in China and Taiwan, and we couldn't import them. So there was a big shortage of oximeters. And our work on the recap score, which stands for Remote COVID Assessment in Primary Care, began because we wanted to find a substitute for the oximeter reading. And we did focus groups, and with general practitioners, we interviewed patients, and we also got hold of actually some of the stuff that Matt's putting in the chat here. So some of the research on the prediction scores of patients who'd done badly. So what would predict poor outcome? And that wasn't great data, because mostly the data didn't start being collected until after the patient had been admitted to hospital. But of course, that didn't tell you who should be sent to hospital. So there was a lot of missing data from people who'd never made it to hospital. Now, on the recap score, we had respiratory rate, we had pulse rate, the kind of things that you would ask a patient. What else have we got, Matt? Can you find the recap score for me? I should know it because I drew it up. We had myalgia was a big thing. One of the things that I suspect might be a good predictor, but we don't know yet, is the level of exhaustion that the patient has. So you will know this if you are talking to patients who are breathless and acutely unwell, that some of them are very, very fatigued, very tired. And we had 2 cases where doctors told us that the patient was so exhausted they could not even speak, which is quite an extraordinary level of exhaustion. And we think that those patients probably were also profoundly hypoxic. So what we're doing, can you expand it, Matt? Because I can't, somewhere in there is the recap score. He's just expanding it. So what we're doing now, and we've got now something like 10,000 patients entered into this study, is we're tracking those different signs and symptoms to find out which ones actually predict hospital admission and intensive care unit admission and death. But we haven't got the data yet. So on the basis of what we think is going to predict, it is the pulse, the blood pressure, respiratory rate, and then obviously things like the conscious level and the red flag symptoms, but the aching muscles, the exhaustion feelings, and breathlessness, of course. But one of the things that you again will know about COVID, or most of you will know, is that bizarrely, patients can be profoundly hypoxic and not feel breathless for interesting pathophysiological reasons. But one of the things that went wrong in the UK early on, and I think in Italy as well, in the beginning, was that people would telephone and they would be asked, do you feel breathless? And they would say no. And so they would then be reassured. Oh, thanks, Matt. Still can't see it. What have we got? Muscle aches, temperature, of course, temperature. And the other thing actually we put in there was prior risk factors. So, for example, if the patient is old and overweight and diabetic, but we've got to be careful with that, because actually the risk factors tell you whether the risk factors are there to predict, but they're not telling you what's going on in the acute situation. And we didn't want to bias the score against a young and previously fit person who was very sick. So we don't load the recap score very much by their risk factors, because as we know, some people are just very unlucky. They shouldn't really have it badly, but they do. And so, yeah, we can just about see that. No, it's no good, Matt. I can't see it. It's too small for me. Let me see if I can find it. I'll see if I can find a bigger version of it, but somehow I can't. Anyway, ask us another question while I'm looking.
Sure. So the other question, which we again we are in a situation where home care is inevitable, and we are using the country's medical body has recommended the use of steroids as well as anti-inflammatory or anti-coagulant in small quantities, in small doses. Has there been any experience of using this in a home setting? Because we have we have a situation where we have to use it in a home setting in the country. You can address the use of steroids separately as well as the use of anticoagulants separately. Was this attempted, or was this used in the UK at all when you had your surge?
Matt will know this better than me, but the steroid, the research on steroids suggests that the only people who benefit from steroids are the ones who are basically very sick and heading for intensive care. So from a UK perspective, those people will almost always be in hospital. Now, when you've got a crisis situation, when the hospitals are full and there are people at home who should be in hospital but who aren't, then it's quite a difficult issue. We never met that issue. I mean, we GPs don't put people on steroids, and I have heard rumor that there's far too much high-dose steroids being prescribed in the community in India. Matt, what have you got to say about this?
Yeah, no, I think Trish is right. So we found, so the guidance is pretty clear. You have to be severe to essentially receive steroids. And there are a couple of articles, and I think the WHO put, and certainly the trial evidence shows less than 90% as being the cutoff. Now, some people use higher than that. And as Trish says, we didn't face this in England, and it is possible to give dexamethasone in the community. There's no denying it. And if you have no beds and you have a patient who is hypoxic, then I think probably the benefits outweigh the risks if you've got someone who is hypoxic. I think the key elements to also add in are pragmatic glycemic monitoring, obviously because of potential high risk of discovered diabetes from that management, and where possible, some form of baseline blood tests, if that's at all possible, for the impact of not only anticoagulation, but also from the impact of the steroids themselves. And we have, and I alluded to this in the talk, because we noted essentially a lot of patients being discharged early from hospital had their dexamethasone stopped. The readmission rate within that group was around 34 to 35%, staggering. So dexamethasone definitely helps prevent readmissions if in patients that you are doing early discharge in. So, you know, in terms of finishing the course, it follows the same adage. Finish the course of steroids if you started it, monitor when you can, be pragmatic and sensible. And you know, the question is whether there are lessons to learn from what Fangdang did with those 13,000 bedded massive hospitals, low acuity, to try and prevent the health system being completely overwhelmed, and whether that has any water. And you know, the authors are really great. They're very willing to be contacted. And what we need to do is learn as an international community, learn from each other, learn what worked, and most importantly, learn what doesn't work.
Thank you, Matt. Rax, are there questions from the audience that we could?
Yes, I can read out, but I think specifically on the pulse oximetry question, because I think it is kind of very important. Maybe Dr. John, you can talk about the respiratory rate. Actually, Dr. John has helped us along with experts from All India Institute of Medical Sciences and CMC Vellore to put together guidance on using respiratory rate and pulse rate and other parameters.
I think can I now share the recap score, because
sure.
I think I may be able to, like I say, this is not validated yet. So we are you know, I'm nervous about sharing it, but I think it's worth just having a look. So the red alert criteria, if the patient is in shock, for example, if the patient is severely breathless, if that breathlessness is new, if it's getting worse, or if there are other red flags like central chest pain, these are obvious red flags. So that's not even about COVID. It's about, you know, sending sick people into hospital. Now, putting those aside, what we've got here, and this is based, as I say, on the subjective clinical experience of doctors and paramedics, 1 or 2 paramedics who've seen a lot of COVID patients. So you can see here, the green is you score 0, the yellow you score 1, and the brown you score 2, and then 3 is basically your red flags. So we've got heart rate, we've got shortness of breath as a symptom, or the measured respiratory rate. Then we've got the trajectory of breathlessness. People who are getting worse, we have a higher index of suspicion than people who are the same or getting better. And then we've got this number 4. We only need one of these, 4A, 4B, or 4C. The oxygen saturation, or the saturation after a short exercise test. If they haven't got an oximeter, you can't have that. So what we're using there is this profound tiredness or fatigue. We don't know yet whether that really will indicate hypoxia, but it might. The temperature, again, this is, you know, the patient with a temperature of 39 is more likely to need admitting than one who's got a normal temperature. But if you can't measure the temperature, either they haven't got a thermometer, or it doesn't work, or they don't know how to use it, feeling feverish with shivers. The patient who has a rigor can often describe that rigor. Patients are actually quite good at noticing that they're having a rigor, or the relative notices. This is not something that happens every day. So if you can get them to describe the uncontrolled shivering. Time from first symptom is important. Now, I think this is changing with the different variants, but certainly when we developed this score, we were talking about day 8 being the day that most people, if they're going to get better quickly, are almost better by day 8. But as we all know, some patients then go into a week 2, which is a sort of more serious, a more hypoxic, a more lung-focused phase of the disease. Muscle aches, cognitive decline, and then we've called this on the shielded list, number 9. But you know, that means that they're vulnerable, they're immunosuppressed, that kind of thing, and then other risk factors. And so we add these up. But you see, you're not far off if you're talking about respiratory rate, pulse rate. We think these are going to be quite high predictors. But we'd be interested to see whether that profound tiredness, the myalgia, will predict hypoxia. So if there's any researchers on the line from India, get in touch with us, because we can now give you a protocol for validating this in an Indian population. We've got colleagues in Brazil who are doing a big validation of this, and we've got 3 different data sets in the UK. So there's my advertising spiel. You just deal with my phone. Sorry about that, I had a phone call.
We have several questions. I'm gonna. I think the protocol with in the UK in terms of the clinical protocol and the Indian protocol seem to be fairly different, because of course we are also dealing with a different potentially a different variant. We still don't know for sure, but it appears so from everything that we have seen. But there are several questions regarding use of antivirals. It's a pretty, I think most Indian governments, as well as the highest medical institutes in India, have recommended the use of Ivamektin both as a prophylactic as well as a weak antiviral. What's your view on that, Trish and Matt?
Well, I haven't looked at the literature for the last 2 weeks, but the last time I looked at the literature, there was no good evidence for Ivamektin, either as a prophylactic or as a treatment. Matt, do you have any other view on that?
The same. I've not seen any convincing evidence of any drug used in the community to improve outcomes, including Ivamektin.
I'll tell you, if I had family in India and I wanted to improve their chances of surviving COVID, I would do 2 things. First of all, I'd get them to spend most of their time out of doors and do all the ventilation that I went through. The other thing I would be doing for my older relatives in particular is managing their comorbidities. If you develop COVID when your diabetes is already out of control, you're going to do worse than if your diabetes is well controlled. And I speak as someone who trained as a diabetologist. Diabetes is a really important thing to think about. I know we've been treating diabetes for years, and COVID is new and it's more interesting, but let's make sure that our patients are as fit and healthy as possible when they catch COVID, because a lot of them are going to catch COVID. So attention to diabetes, to people's blood pressure, to their heart failure, whatever comorbidity they've got, if we can shape them up with that. And of course, the other thing is hydration, all those kind of things. I know some people are I think it's still Ramadan. If people are weak and frail and a bit feverish, they should not be fasting, and you can talk to your imams about that. There's a perfectly good escape clause. They can pay the days back later, but I think that people are actually in the UK now, they're being quite sensible about that, and the religious leaders are supporting us. I don't know whether you've got anything to say about that, Matt.
Well, I agree with what Trish has just said. I think the only other thing, certainly what is not associated with any harm, is self-proning. Certainly I tried to teach as many colleagues, and there's many of my friends and family who came down with COVID symptoms, how to do self-proning at home, in the hope that it would help recruit alveoli and help with the respiratory rehabilitation element. We have no evidence to back that up, but we do it in hospitals and it appears to work. I have to say that I don't think there's any harm associated with it.
Thanks, Matt. We have in fact got self-proning and guidance on self-proning as part of the protocol, and we send it out to all our patients who are managed at home. Again, might not be fully backed by evidence, but at least what we're hearing is that it is useful.
Yeah, what we hear as feedback is after self-proning, patients see a 5 to 10% increase in saturation levels, which is typically gets them over the over the line in most cases. At least
we've noted the same. It was about 5%. I mean, the study we did was only about 50 or 60 patients, but it appeared to make a difference. We need to publish. We need to get this published at scale. The other thing to say is anxiety, breathing anxiety. Exercises sometimes help as well, and it's obviously a difficult balance because you want some anxious patients who are genuinely hypoxic to seek help as well. But there are larger numbers of patients who actually have normal oxygen levels who feel understandably profoundly anxious, and managing that health anxiety together with normal oxygen levels and no red flags is an equally really important element to try and protect the healthcare service utilization. And also rehabilitation, because the crossover between what is acute short-term COVID and long COVID, I think is a really important one, and part of that is management of cognitive processes and anxiety.
Okay, we have another question. Any experience with managing asthmatic patients with COVID?
Clinically, we did not see as much bad asthma during COVID as we were expecting, and that really prompted a lot of thought around whether asthma steroid inhalers were going to be of use in the therapy of COVID, hence the budesonide trial. But unfortunately, what we've then been able to prove through a collaboration called Open Safely, which is based in Oxford and also nationally, is that unfortunately asthma does not appear to be protective. It isn't particularly associated with severe outcomes either, unless you've got someone who's required oral systemic steroid treatment or has had recurrent acute exacerbations. So it isn't unfortunately protective. We haven't seen as much of it as I would expect, or we would expect, but it doesn't appear to confer a survival advantage either.
Thank you. The next question is from Dr. Madhumati. In India, we are recycling pulse oximeters because we are it's a full resource. Any experience with that and how to sanitize and use them carefully? Has that been done before?
Okay, this is one of my favorite subjects. Look, nobody has ever been documented as having caught COVID from a pulse oximeter. There's never been a documented case of anyone catching COVID from a fomite. In other words, any object, a mobile phone, a telephone, a teacup. The virus spreads mostly through the air. So having said that, you can wipe it down with whatever you would wipe a surface down with. You don't have to be theatrical about it, is my view. I think when you think how much benefit someone will have from using a pulse oximeter if they are sick, the risk is tiny compared to the potential benefit. Having said that, yes, of course we would wipe it down. We wipe it down even if the patient didn't have COVID. That's just, standard cleanliness. But we don't have to go crazy. Am I right, Matt?
You're spot on. I've popped in the chat the decontamination guidance we released in case useful. It's pragmatic. And as Trish says, a few hours in the open air is enough to properly decontaminate anyway. But we do tend to wipe down. And as Trish says, 0 reported incidents of cross usage contamination. And I just want to reassure you that we are absolutely recycling our oximeters in England. We are not giving them out. We're not, although we may have some resource, we are certainly not just getting rid of them and treating them as disposables. We don't have that luxury.
Okay. One of the biggest challenges in home treatment, Dr. Ramita Pai, I think, is asked this question. One of the challenges in our country, in India, is the testing infrastructure is not uniformly available. So to have a home treatment protocol which requires the patients to frequently go for get their blood work done is a challenge, and we are trying to minimize the number of times the tests need to be done. So what's the right balance there? What are the absolute must or is there a risk score based testing methodology or strategy that we could adopt into our protocols? Because it is a big challenge for us, not just in terms of availability of infrastructure, but the sheer load that is there on the system, which is making clinical treatment more or treatment based on clinical science more relevant than evidence-based on tests.
Absolutely. And this was where we were last March and April, which is why we built the recap score the way we did. One of the things that I feel is very important is that, yes, there's a lot of testing, but when COVID is spreading really rapidly and extensively in the community, an awful lot, I'm not saying every patient who's got symptoms compatible with COVID necessarily has COVID, but the pre-test probability of this being COVID is very high indeed, even if the signs and symptoms are atypical. So the elderly person who's off their legs and confused, the patient who's got mainly abdominal symptoms, etc., etc. I know my son is a junior doctor, and he worked in the front line of COVID, and he said everybody who comes in tests positive for COVID. Now that was back last March, but in a way that's where you are at the moment. So I'm not saying assume everybody's got COVID, but it's actually not a bad rule of thumb. So yes, sure, all that testing and pursuing and repeated testing, maybe that's something to put aside for when the virus isn't quite so prevalent in the community. Right now, you can almost, but not quite, assume that if the patient has got a compatible story, they're likely to have COVID, and you should treat them accordingly. And in a sense, if they've got something else, if they've got a bacterial pneumonia, I think that will emerge. But mostly, given that there isn't a specific treatment for the patient in the community, it's hydration and monitoring, et cetera, et cetera. You're going to be doing that for anyone anyway. So I think it's about managing the uncertainty partly. And I think you can be reassured that there isn't a kind of magic thing that you should be doing. It is just a question of what we call expectant management. And protect people from overprescribing is the other thing. Protect them. They don't need high-dose steroids. They don't need ivermectin, whatever else. I'm seeing some really scary reports of alternative remedies made from cow dung and all this kind of thing. I don't think that's what everyone's getting, but I think, it's fluids, paracetamol, the standard stuff, and very importantly, monitoring them and safety netting, making sure that they know what to do if they deteriorate.
Yeah, Trish, the question, thanks. The question was not really on testing for COVID, but also testing other tests like your blood work, the CBC, or the complete blood count, testing for D-dimers, testing for CRP levels. Those things. How much of that is a must? Because we are seeing that there is a lot of that being prescribed, and that's causing some stress on the healthcare system, because we don't have. Yeah.
Can I take this? Because I agree with Trish on this. We need pragmatism here. And I don't think anyone, even the most advanced proponent of biomarkers, would suggest use a blood test or use a complex radiological test, or indeed a PCR above a combination of physiology and clinical judgment. So I would pretty much set a very clear label in the sand. And although, in the UK we're very fortunate in being able to send CDCs and D-dimers on most patients, actually they only rarely influence what we do with the patient. And if someone's hypoxic and they are symptomatic and they're at risk, they're coming in. it doesn't matter what the blood test shows. It helps tailor the treatment a little bit. And in some cases, it helps when there is a differential diagnosis, when we are worried about what else could be present. But our research studies show that even those presenting with COVID, only 6 to 7% have a superadded bacterial infection. And our mistake in England was giving 100% of COVID patients coming in antibiotics in fear that they may have a superadded bacterial infection, but actually the evidence shows different. So clinical judgment is really useful here. We should always think about what else could be present. But as Trish says, in the depths of a pandemic, 70% of the time, it's going to be COVID. And, that is certainly the figure we arrived at during first peak and the high parts of our second peak of COVID, that actually even an ambulance triage person taking calls from the general public got it right 2/3 to 75% of the time on the phone in terms of the diagnosis. So tests and blood tests can introduce costs, worsen inequalities, introduce further delays, and actually stop the management of those who require hospital attention sooner, particularly if you're only waiting for a blood result. And the question is whether greater energy should be diverted into what lower acuity admissions could do to try and get to the fact that there are a lot of people sitting at home hypoxic and deteriorating with nowhere to go.
Okay. The next question is, how effective is a 6-minute walk test in predicting happy hypoxia?
Now, our team did a systematic review on this. First of all, if you've got somebody who is acutely unwell with suspected COVID, please don't do a 6-minute walk test. That's not what they need. If they've got hypoxia at rest, they shouldn't have any exercise tests. So the desaturation is only for people whose oxygen levels are normal at rest. And then I would do a shorter test. Now, interestingly, the 6-minute walk test, I mean, it's impractical. How many people have got 6 minutes to spare walking around with the patient? You haven't got that. When we're doing it over the phone, we tell them to take 40 steps around the room. But the other one that we looked at in the systematic review was the 1-minute sit to stand test, which sounds really easy. But if you try it, if you go home tonight and try it and see how many times you can stand up and sit down in a minute, you will be tired at the end of it. You will be completely exhausted, which is why we wanted a gentle test for the 40 steps around the room. So yeah, desaturation on a short, not particularly strenuous exercise test is a very bad sign indeed. Wouldn't you say, Matt?
Yeah, and there's actually a few papers that have been published recently to demonstrate both the threat of silent hypoxia and the superadded threat of those who become hypoxic on minimal exertion as predictors of who will then need an oxygen in the future and secondly, require an intensive care admission. So definitely do it. Be pragmatic, as Trish says. 40 steps is certainly adequate. There are multiple research groups that are studying this at the moment. And again, if the research is on the line, we would love to be able to power the studies with patients from India as well, because we still need to prove and validate this. Are people in the call able to see the chat? If not,
no, actually, I'm actually sharing this on the YouTube link. What you're posting here, Matt.
Oh, thank you. Thank you.
Yeah.
Yeah.
One more question. It is pretty generic. I think you have addressed this, Matt. This is from Dr. Abhiruchi Tuli. Your experience on how effective is giving antibiotics in COVID. I think you addressed that, but maybe just addressing that separately will help.
Yeah, so it doesn't help. And, the worry is it can actually do a bit of harm. In the initial phases, a patient coming in from the community with an emergency deterioration due to COVID has about a 6 to 7% chance of having a superadded bacterial pneumonia, so very low chance. And yet we gave them all antibiotics. We still do it because of fear and because of just in case type approaches, unfortunately. And the worry is that it will increase resistance for when they really, really need antibiotics. And if it's a patient that's going to be in for a month and on a ventilator, you need to preserve the effectiveness of your antibiotics. And the longer you're in hospital and the longer you're on intensive care, particularly, you've got the higher risk of developing a superadded nosocomial pneumonia. And we are seeing an increase in those in patients that have had long stays within hospital. Another good reason to keep people out, another good reason to avoid antibiotics where possible. And then, another reason we should be looking at evidence rather than, our own fears about what might be wrong.
Okay, thanks, Matt. On project step 1, actually coming back to the 6-minute walk test, what the triage protocol talks about using a 3-minute walk test in cases where the people may have normal levels, but they don't have an aerobic lifestyle, or they don't have normally an exercise lifestyle. They are about 60 years old. Maybe have you seen this recommendation before?
I know when in the chat we've put in a systematic review. We looked at all these tests. There were the 3-minute, there's a 2-minute walk test, there's a something else, there's a 3.5-minute test. There's actually also a test of putting things in cupboards. There's these sort of activities of daily living, and instead of walking around, you get someone to do something as if they're in the kitchen or something like that. So there's loads and loads of these tests. But they've none of them been validated for COVID-19. That's the first thing. Most of them have been used most of the time in COPD or chronic lung disease, and whether or not they are valid for assessing the acutely unwell person with probable COVID, we don't know. But I wouldn't go too crazy about these, because, as I say, what we have shown is that if the patient is hypoxic at rest, it's dangerous to do any kind of exercise test. And if you are going to do an exercise test, the practicality is that the patient may not be in the same room as you. You may not be there to resuscitate them because they are at home and you are in clinic and you're speaking to them on the telephone or something like that, which is why we wanted to recommend a very gentle test. If you're talking about the patient has come to the clinic, again, I wouldn't be too obsessed with a particular test. I mean, you can walk the patient up and down to see if the oximeter level comes down. But one thing we did find in that systematic review is you have to keep the oximeter on the finger for a full minute after the end of the exertion period, because sometimes the oxygen levels don't fall until after the patient has finished exercising.
Great. Actually, I think we are almost over our time, so we will. This was extremely useful particularly for some of us at Project Step 1 who are working on these protocols and have the ability to have a large number of clinicians adopt the protocol, which is hopefully validated by studies, and also quickly use our own experiences to revalidate and tell the world about how some of these things will work. I certainly have taken away a few things which I want to discuss with Dr. John and some of the others with respect to our protocol, which we are currently using for telemedicine and telemonitoring of patients. Certainly has been very, very useful. I hope we can adopt some of these things very quickly. Dr. John, over to you if you want to summarize and.
Thanks, Rag. Thank you, Trish and Matt. It's been extremely useful, and we really hope to work closely with you as we refine our protocols and try to embed as much of the evolving evidence as we speak. And also, we have a large number of doctors who are enthusiastic about making a difference and making sure that the evidence as it is evolving reaches them in the quickest way possible, so that we can all make a difference. So thank you so much for your time, your collaboration, and all your support. So, and thank you. Our doctors are really fatigued, and they have spared close to 1.5 hours to be with us this evening, and all the volunteers as well. Thank you everyone who is on this call with us. You guys are doing an amazing job, and thank you. And I want to thank all of you on this call, and Trish and Matt and Rags for hosting us.
Well, thanks to everyone for joining us. We hope it's been helpful. If you'd like us to do it again, or cover other subjects, or find other people to talk about topics, it's the least we can do. And we're praying for India. We really are.
I echo that, and I'm completely amazed and incredibly impressed by the dedication and the initiative you've shown with this venture, and the ventures you are providing at some massive scale. Hats off to you, and like Trish says, anything we can do to help, just ask.
Cheers.
Thank you. Thanks.
Thank you.
Thank you all. Thanks, Trish and Matt, once again. I really hope we can get over this this crisis very soon with support of so many people. Thank you.